technique. It obviates the need of fragmentum and PFCL. However, every technique comes with its own disadvantages, and this described technique is having possible damage to the corneal endothelium, for which the surgeon must use adequate amount of visco, and iris should be protected, and also the macula should be protected, because there is theoretical chance of injury to the macula by falling down of the cataratus nucleus over it. For large nucleus and small people, it poses a big challenge, so the people must be adequately dilated, and 25 gauge vitrectomy is a difficulty for this technique, so we must do with 23 gauge vitrectomy. In summary, vacuum assisted levitation technique is useful in resource scarce situations. All of us know there might be some surgeon who is not having fragmentum, or at a remote place PFCL is not available, like that, and the people must be well dilated, and with a small cataract and intact capsule, it's a very good indication for this. However, we must know that it's not a substitute for the traditional pars-final vitrectomy plus pars-final lensectomy. Thank you.
It was a very good presentation by Dr. Ranjan, and as we know that having a dislocated or subluxated lens is what we encounter in our daily surgical cases. So we'll have the questions about the same in the next, or maybe later after all the presentations are done. We'll have the next presentation by Dr. Anirudh, where he'll be discussing about learning lessons in surgical management of retinal angiomas.
This presentation discusses the management of a patient with bilateral multiple retinal capillary hemangiomas, highlighting several nuances and learning lessons. Our patient is a 29-year-old Asian Indian girl who presented with sudden decrease in vision in the right eye. Examination revealed visual acuity of hand motions close to face and a combined retinal detachment with a tractional fold involving the macula extending inferotemporally and several retinal capillary hemangiomas in the right eye. The left eye showed a large inferior hemangioma with a feeder and a corresponding draining vessel. Given the clinical presentation, it is essential to perform a thorough systemic workup prior to any surgical decision making. Our patient underwent blood pressure monitoring, measurement of urinary vinyl mandelic acid levels, and imaging, which revealed cerebellar hemangioblastomas and pancreatic cysts. Our first learning lesson is that in the presence of underlying systemic lesions, especially pheochromocytoma, any surgical intervention can be catastrophic. Another important aspect in the management is screening of family members. Ultra-wide field imaging of a brother revealed small retinal angiomas. Remember, family screening could be life-saving. Due to positive family history and systemic lesions, our patient was diagnosed with von Hippel-Lindau-related retinal angiomas based on the Danish and international criteria. In these cases, various surgical complications have been described, including intraoperative bleeding, post-operative epiretinal membranes, and recurrent angiomas, among others. In view of combined retinal detachment involving the macula, we decided to proceed with pars plana vitrectomy in this case. We performed the surgery under local anesthesia, as these cases usually do not need hypotensive general anesthesia. The recti were bridled and a 240 band was passed 360 degrees. We also applied 277 tire in the inferotemporal quadrant to support the peripheral retina. Following the application of scleral buckle, standard 25 gauge pars plana vitrectomy was initiated. The retina was inspected and core vitrectomy was performed. A large raised retinal angioma was located superiorly. The vitrector was used to gently separate the vitreous adhesions from the angioma. Another angioma was located inferiorly. These angiomas can bleed a lot, making it a very challenging situation. Remember to be very careful and precise with the cutter, or else you could end up causing catastrophic damage. Slowly but surely, the angioma was excised with the cutter and endodiathermy was applied. An important lesson is to keep endodiathermy ready, since these cases can have torrential bleeding obscuring the surgical view. Perfluorocarbon liquids may also be kept standby. There were other angiomas in the superior retina. The vitreous connections between them were carefully removed. The feeder vessels at the base of each angioma were cauterized. The diathermy needs to be applied several times to ensure complete hemostasis. Peripheral vitreous-based shaving was initiated before tackling the retinal fold and the inferotemporal angioma. Triamcinolone was used to stain the vitreous membranes so that the retinal fold could be dissected. An important lesson is that eyes with hemangiomas commonly develop epiretinal proliferation, which needs meticulous dissection. Tano's diamond dusted scraper and internal limiting membrane forceps were used to remove these membranes to relieve all the traction. We decided to perform inferotemporal retinectomy. Prior to retinectomy, perfluorocarbon liquid was injected to prevent the possible accumulation of submacular hemorrhage. Endodiathermy was used to mark the area of dissection. Retinectomy was carefully performed. The large orange angioma can be seen inferotemporally. Perfluorocarbon liquid was used to flatten the retina once all the traction was relieved. Laser photocoagulation was applied all around the area of retinectomy. Finally, the perfluorocarbon liquid was exchanged with air and silicone oil was injected for internal tamponade. Post-operatively, visual acuity was counting fingers at 3 meters. The retina was flat and the area of retinectomy was well supported on the 277 tire. OCT showed a flat macula.
It's the one and only Digo Double G. You know what happened with it.
To conclude, although VHL-related angiomas requiring surgical intervention are rare, meticulous preoperative ocular and systemic workup and careful surgical planning may help in improving visual outcomes. Thank you. This
Very interesting case and very nicely managed by Dr. Anirudh. I would call upon Dr. Divyansh Mishra if he can come on the dais, and Dr. Bhavik Panchal if he can please come and join us on the dais. And your take on this, Dr. Chitranjan. In the meantime, we need to call upon Dr. Divakant Mishra for the next presentation. Dr. Divakant would be presenting a very interesting case on a surgical approach of a case in in intraocular cysticercosis. So, Dr. Divyansh, what would you want to speak about the previous case?
Very nice surgery shown by Anirudh. Fast, fast, fast. Interestingly, I would not want to do any RR in cases wherever angioma is there, because the only issue is that whatever angiomas which we are seeing right now, because we are expecting to have more angiomas which may occur at other areas in the retina also later on, and these cases over a period of time develop very significant AHF proliferation, and they may have even a vascular AHF proliferation. So my take on this would be to avoid RR or a retinectomy as much as possible, and try to manage a case if it's possible with a buckle or an additional encerclage with a band, or having a very high indent. But RR would be my last and the final option, because beyond this, the survival of the eye would be very, very less. And as we can see, even after the surgery, also the visual improvement is very less. So, and these patients have bilateral involvement because of the VHL association. So, such cases, ideal would be to avoid any aggressive surgeries and try to do a stage-wise procedure, like try first a buccal band, and then if it doesn't help, then probably try to remove an ERM later on, and try to manage with laser. If the larger angiomas are there, you can use even brachytherapy, but the availability is a big issue in that. In India right now, the BARC is working very hard, and then whatever BARC plaques are there, those are very cheap plaques as compared to the foreign plaques which we had before. So it would also help in such cases.
Thank you, Dr. Divyansh. Over to you, Dr. Divakar.
So thank you, Dr. Avanish, for inviting me to be part of this session. So I'll be talking about a case of intraocular cysticercosis, a submacular one. All of us know that cysticercosis is a parasitic infestation which is caused by the larva form of the cystode Taenia solium, and it apart from its effect on the eyes, it greatly affects the central nervous system in form of the neurocysticercosis. And in the eye, it can lead to various lesions like a subconjunctival cyst, cyst floating in the anterior chamber, intravitreal cyst, or a subretinal cyst, as we would be talking in this case.
Segment evaluation was normal. Posterior segment revealed a yellowish subretinal lesion involving the fovea. Certain relevant investigations were.
So the CT scan of the brain was also done, which was unremarkable, and a neurology consent was also sought before going ahead with the surgery.
Advised to the patient. The OCT revealed a large hyporeflective cystic lesion along with a hyperreflective wall with something that looked like a scolex attached to the wall of the cyst. Rest of the investigations were unremarkable. So clinical diagnosis of subretinal cysticercosis was made. Patient was put on oral steroids and vitrectomy was planned. 25 gauge 3 ports were made. Core vitrectomy was performed, and if you notice keenly, the classical undulating movements can be observed here. PVD induction was tried first without triamcinolone. Then triamcinolone assisted PVD induction was successfully done and a complete vitrectomy was performed. After the removal of vitreous, we could see a macular hole that had also.
So just post the PVD induction, we could see that large size macular hole had also developed. A small retinotomy was made at the edge of the cyst to access the subretinal space. Through this retinotomy, active extrusion was used to bring out the cyst in toto. The macular hole was more apparent at this stage. The highly compressible nature of the cyst can be appreciated here, as it is removed totally through this small retinotomy. This prevents any collateral damage to the surrounding retina while its removal. Then the cyst was eaten up at high suction and high cut rate with the help of the cutter.
Fluid air exchange was performed. The subretinal inflammatory debris and the SRF were carefully removed from the retinotomy that was made earlier. The retinotomy site was then lasered with very light burns in a single row. SF6 gas was then injected, and after that, the patient was advised to maintain prone position for another 1 week. So we got good outcomes after the surgery, a vision of 618, and the hole was closed.
Thank you so much.
Excellent surgery, Dr. Devakant, and very meticulously done. And having a thorough workup is most important before actually going in for surgery. One thing we need to discuss is whether actually lasering that area would have been done, or whether we could have just done an FAX. And secondly, actually, if there is a bigger hole like this, which is very much in the posterior pole and in the macula, whether doing an ILM peel and just keeping it over that would have been an option.
So the retinotomy was, I felt it was a bit bigger on the bigger side, so I thought it would be prudent to laser it. And I felt that the macula that was looked quite fragile, so an ILM peeling or something of that sort would have been very difficult in this situation. So, but the hole closed well post surgery, so, and it was not due to any tangential traction or anything. So I think we would get results without ILM peeling.
Dr. Bhavik, your take on this?
So the preoperative cyst and intraoperative cyst was the same location.
Yeah.
So most likely the cyst was dead. That is what you think?
No,
because normally they keep on migrating. Because what we see in the OPD, and when you plan for surgery, the cyst may not be present in the same level. Sometimes it can go from subretinal to the vitreous space.
Because the gap between the first, because it was a referred case, so it's almost within 24 hours we had operated the case.
Okay.
So, but almost, yeah, it was on the same location.
Yeah. So only point
it was not dead because we could see the movements and also.
Dr. Kumar, you want to add?
I was just wondering about the macular hole that was present, which I guess, yeah, as you said, that the ILM peeling would not probably have been the best idea. But what do you think is the mechanism here of the closure of the hole? Because the hole probably was created after the PVD, because we could not see it on the OCT. So, I mean, what probably is just the closure mechanism here? Did the gas help, or?
The hole, I think, was formed with the jet of the triamcinolone. Maybe, I think that was the mechanism of its formation. Because when I hit the jet, I could see at that moment. I'm not sure whether it was due to the PVD or because of the jet of the triamcinolone.
So I feel the reason for hole occurrence because it was already tented for a very long time and it would have got thinned out. And when we are inducing a PVD, that's the most thinnest part of the retina, and then that has just yielded off. And as you could see, because of the PVD, there is an anterior-posterior traction, and because of that itself, like that's what the mechanism of hole formation. And the vitreous usually in young patients are attached at the fovea also. So means I would have tried to do like a donut vitrectomy. Obviously, all that retrospectively we can think and then try to do whatever is possible. He did his best, and the results are very good. One more thing which I would have wanted to do was to peel ILM and not to do laser at the site of that drainage retinotomy, because once you peel the ILM, the chance of the detachment are very, very low. And as you could see that after the laser, because the retina gets also thinned out. We could have added laser post-op with like a focal barrage kind of a little more control, because as you could see that whenever we use a laser which is intra-op, obviously the distance and the power and all is completely different. The scarring is different, but fantastic.
So even in submacular hemorrhages, we see that when you go and operate, there is a tendency for the hole to form, right? So because of thinning which happens over a bit of time.
So one more thing, whether we would have just left it with a fluid gas experience rather than putting in a gas for the stomach.
Choice is very personal, but obviously young patients we are thinking more into, so that's choice is
And in case, like if we actually are taking the cyst out and if it actually kind of bursts, so then it's difficult to actually manage that. So the thing is, the way we actually went very like it should not burst. This is what the idea is.
So I have seen Dr. Mahesh operating such cases by doing a like not such posterior, but near to equator and just posterior also to remove it transclerally.
Right.
So not even to do a vitrectomy. So we have seen him doing all that, but yes, we have seen him doing vitrectomy also. Even if the cyst ruptures, the only thing which in the previous literature has been mentioned is a significant vitritis post-op. But because the right now all the vitrectomy systems are so good that all the whatever the coagulum, once it gets dispersed, it's washed out also easily. So that is not expected. Even if it ruptures, it doesn't have any issues.
You don't tend to see the vitritis.
That's true. Yeah.
Dr. Mahesh, any comments pertaining to this case about what we could have done in a better way? Because we're all learning here. Or any alternative approaches?
I would have pretty much done the same way. Whether we could have peeled the ILM and left it to close the retinotomy to drain to remove the cyst, I would have probably done the laser, because there is some amount of inflammation in the area of the retinotomy because the cyst was there, and there is usually some amount of inflammatory debris there as well. So that retinotomy I would have probably lasered, and ILM, yes, of course, for the macula hole I would have peeled it and left it like that. You could see that white ring around the cyst indicating there was an inflammatory material. So I would have probably lasered it as well.
Thank you.
Thank you, sir.
Thank you, Dr. Thank you, Dr. Devakant. You can comment. And our next speaker is Dr. Bhabe. He'll be speaking about looking beneath the retina, management of subretinal bands in PVR. Dr. Devakant, if you can join us here. Dr. Komal, you can join.
Okay, so good morning everyone, and thank you Dr. AWANEESH for inviting all of us here. So I'm going to start with the case. This is a 27-year-old male who had a corneal tear repair and traumatic cataract surgery done elsewhere a year ago, and he had a good vision, decent amount of vision, and he came with vision loss to us. So his vision at the time of presentation was 21/25, and the left eye was unremarkable with 20/20 vision. So in the right eye we see a corneal scar with a peripheral anti-cyanic, cataract with multiple pitting on the IOLs, multiple lasers were attempted to remove the capsule behind the IOL. And if you look at the fundus, there was a hazy view, but there was a retina detachment, and there was an irregular retinal surface with kind of tenting which was present here, right? And if you look at the B scan as well, so the B scan also showed that tenting surface which was noted. So if we compare here, clinically you could make out there was a subretinal band which was passing across the retina and close to the disc as well here. So just a short video of, so the core vitrectomy was done for this patient and ensured after the encirclage was 240 band was applied, ensured the entire peripheral vitrectomy was completed. And then if you look here, a small axis retinotomy which was made over the subretinal band using a maxillary forceps. The band was removed through the drainage retinotomy itself, and the band could come in toto. Some part of the band, the extension of the band was from the inferior retina going until the nasal retina. Some part of the band remained towards the nasal retina, did not come, and then it was laser was performed and silicone oil was injected. Okay, this is post-op day 1 picture. This is just a recent surgery, but the band was not there. There was no traction, and the patient had decent vision as well. So PVR can complicate regmeton's retinal detachments, and this contributes to poor visual outcome. And this basically PVR is an irregular scarring process characterized by growth of membranes on both the surface of the detached retina and also onto the vitreous. So just for people here, if you look at the grading of PVR, the updated Retina Society, grade A indicates earliest process with pigment clumping in the vitreous. Grade B indicates rolled edge of the retinal tears, and grade C indicates formation of pre-retinal or subretinal bands. So here we are dealing with the grade C PVR. So management of subretinal bands can be complex. It can be either observed or intervention might be required. So let us look at the scenarios where an intervention is required, or we can observe the patients. So observation is required, or it's indicated when a subretinal band is present in the periphery and there is no traction on the macula, okay, and the vision is maintained. Or in certain areas you have traction in the periphery and only a scleral buckle can be performed for such individuals. Whereas when you look at traction which is involving the macula and you feel that okay, this patient needs surgery and you have to remove the band as well because it's not going to allow the retina to settle. So along with the encirclage, vitrectomy can be performed. And if you look at the approaches to remove these bands, it can be either a subretinal approach or via an axis retinotomy. Okay, so what is the best approach? So we have to assess the amount of traction and the status of the vitreous. Okay, so say for a scenario, young patient, the traction induced by the subretinal bands which is away from the macula, maybe a scleral buckle is indicated, or traction posterior and more significant, removing the band should be considered at the time of the retinal detachment repair. Subretinal bands can be removed via axis retinotomies, or you can also make larger retinectomy to allow the peeling of the membranes around, and an entire sheet of the band can be removed, or a retinectomy can be performed that excises the subretinal bands altogether, and the area of retina itself can be taken up to relieve the traction. So this is a video where we see that an axis retinotomy is made, just similar to our case. Okay. And again, this was made over the band, and through the axis retinotomy, the band is removed in toto. Right. So this allows for the retina to settle, and there is no traction which is present. So the next question arises: where to place them? Where to place your axis retinotomies? Do you place over the band itself or adjacent to the band? Right. So here it's important to understand that if you're placing it over to the band, there is a chance that you can damage the band and the band can itself snip and it may retract. Then it's difficult to go and retrieve. If it retracts and still there is no traction, that your job is almost done. Whereas other way around is that you make a drainage axis retinotomy which is adjacent to the band, and from there you can take your forceps and you can remove the band. Right. So anticipate the angle at which the forceps are going to bend, and you're going to capture or take your subretinal membrane out. The band has to be removed slowly with attention to the retinotomy, because there is a chance if you try to manipulate a lot, the retinotomy may actually increase in size. Okay. And large bands can be removed with use of a chandelier and bimanual technique as well. So just to conclude, PVR complicates regmeton's retinal detachments. Subretinal membranes causing traction can lead to recurrence, and the subretinal membranes with no traction or traction away from the macula can be either observed or a scleral buckle can be performed. And causing traction at posterior pole, vitrectomy with encerclage is the way to go ahead. Thank you so much.
Nicely explained, Dr. Bhavik. So, how often actually do you go with? Do you actually go in removing bands, subretinal bands for all your cases, or you actually have like this is a case where you decide pre-op that, or maybe on table it sometimes happens that you are trying to settle the retina where it is more extramacular. So, can you give one or two pointers on the same?
Yeah, especially say young patient post trauma and you have a subretinal band which is traversing through the fovea, okay, and you have an access to it which is away from the fovea, away from the arcades, and that you know that the band is also contracted, it is not going to allow the retina to settle down. So those are the cases where I'll go and remove the band. If I have peripheral band, okay, and I can manage with the buckle, I'll not do a vitrectomy for such individuals, especially post trauma dialysis. You may not go ahead with the vitrectomy, and the bands can remain there. Okay, and if it's not causing attraction, the retina can settle this.
I mean, most of the times we do tend to see if there is more tenting, during the surgical, when you start up with the vitrectomy, that is the time where you see that if the retina may not settle, there would be some subretinal, the retina is not settling. Those are the times we'll decide that these are the bands which needs to be removed. As you said, not all bands should be removed. One more thing was when you are actually pulling out the bands. So do you use any specific technique like the spaghetti technique, or
Yes.
how do you go about looking at the band that this is how you would want to, if you can give some?
Yeah, so some bands are quite tougher, okay, and you tend to pull it and you realize that there is a stronger adhesion. That is where itself you can actually have the spaghetti roll technique and they may come up into your forceps.
So that was very nice, Bhavik. Uh, I guess it's important to note the point of discussion here is that not all subretinal bands might need removal. It's basically if there's just a focal traction or a focal star fold which is not hampering your retina reattachment, then you might just leave it. I guess the more important ones are the circumferential ones, which are more difficult to remove. And for those kind of bands, either the retinotomy would probably be adjacent and not on the band, because
True.
just by breaking the band, you're not relieving all traction. So the kind of band and the direction in which the band is going to assess that intraoperatively is quite important.
Thank you.
Dr. Bhavik, nice presentation. How about approaching it from the outside through a sclerotomy, more posteriorly located sclerotomy?
I have never tried that. I have no experience with that.
We tried in one case with extensive band. It worked really well. Dr. Naresh Babu had also shown in one of his presentations.
But Dr. Devakant, in those cases, I mean, what actually happens when you're going from outside? Uh, there is sudden SRF which kind of comes out. So when, I mean, those are the times when the retina, there is a very high chance that you may actually cause more damage to the retina.
You
Right?
just need to use a walled cannula. And so, yeah. A more posteriorly located sclerotomy and using a walled cannula so that there's no gush of fluid.
Thank you, Dr. Bhavik.
Thank you.
So now we'll have Dr. Avnish with his presentation.
Huh?
I guess we are a little short on time, so we'll rush through our presentations and we can keep some time for discussion at the end if the time allows.
We all know macular holes are anatomical defects of the fovea resulting in decreased vision. We do surgeries when there is stage 2 with less than 400 microns, or stage 3 and stage 4, we think about doing the vitrectomy with ILM peel conventionally. We know that the chances of actually having a risk of failure of macular hole surgeries would be when the size of the hole is very large, or if it is more chronic. So the strategies for refractory or failed macular holes is doing ILM peeling from arcade to arcade, or maybe using a scaffold for with the ILM. And you can have free or pedicle grafts where non-inverted ILM peeling is done. And then there is this scaffold of tissue alternatives which are available. So this is the conventional technique which we tend to do, where we do a vitrectomy followed by ILM peeling, and we do this is like my earlier videos. We used to do multiple flaps around the um, macular hole and try to use the ILM as a scaffold over the macular hole. You can see slowly that, and then we shave it off as much as possible, and then we try to use this as a scaffold. The other techniques are what we discussed was a free flap or a pedicle flap, which can be used. And later ones are the ones where you have scaffold using alternatives like a lens capsule or an amniotic membrane, or autologous retinal transplants. So I'm going to show a couple of cases where I have used different strategies depending upon the situation. Now, this is a patient who had a recurrent the failed macular hole, and it's a largely you can see it's a huge macular hole. We tried to do a massage and reduce the size of the hole. Initially, I thought that I had not possibly done an enough ILM peel, and that I would use it in the next go. But here I see that I have done a very nice ILM peel in this patient. So then I thought there was some pedicle graft which was possibly there, and under PFCL I tried to mobilize it over the hole. You can see it was nicely slowly maneuvered over the hole, and now during the fluid air exchange, uh, this is what actually happens, where with the flute it kind of goes into uh, the ILM kind of is sucked up with the the flute. So here in this patient, I wasn't ready about. I didn't have an amniotic membrane or something, but here we have actually used the anterior capsule, where we have nice. It was kind of there away, and we used, and we like we nicely dissected it here, and we used this anterior capsule here, and that was maneuvered within the eye, and we had mobilized it over the macula. And we tried to, we had this fluid air exchange, and we closed this hole. So we use gas after once the flap was maneuvered over the retina. So this was 3 weeks post-op. You can see the hole is kind of closed with the anterior capsule. Now this is another case where we had a retinal retinal detachment with PVR changes, and we were doing the we were removing the membranes over the retina under the oil. And during this procedure, I had this iatrogenic large macular hole, which is not captured here. So at that period of time, this patient actually had the posterior capsule of this patient was also compromised, where you can actually see halfway here. It's like it's hardly a posterior capsule is there, and I didn't have any other resort of actually closing the hole. And I was more of, it's not about the hole. I was more concerned about having a re-detachment because of the hole. I didn't actually go in for doing another taking a retinal graft here, because I was kind of scared that it may induce more PVR changes. So in this case, what we did was we went ahead, tried to remove ILM as much as possible, and then we did an FX exchange, followed by maneuver reducing the size of the hole. And here we have used the corneal epithelium as a scaffold to keep it over the macular hole so that it does prevent from redetachment. We have sent this to couple of we have sent it for review, and it is under review for publication. And second thing, here they say that the corneal epithelium can cause hyperplasia, but in our case we didn't actually have any hyperplasia or the any inflammation post-op. Secondly, the corneal epithelium kind of actually got amalgamated in within the hole, and the size it could it shrunk. And I have post-op I have been following this patient for more than a year now, and here you can see after putting the oil, the graph which we had put, that has kind of moved away, but again we have maneuvered it over the hole. So the primary thing which we did was using uh, uh, the the graft was to actually prevent from recurrence of a retinal detachment rather than closing the hole. But this is how it is. This is almost like 2 to 4 weeks after the surgery, and you can see the hole is also closed. The retina is normally attached. Thank you.
Thank you, Dr. Avnish. Very nicely demonstrated different approaches to a refractory hole. Because we are short of time, we'll just go ahead to the next presentation. Next would be Dr. Divyansh Mishra, and he would be discussing a case of a long-standing paramacular intraocular foreign body.
So, good morning, all. So, this was a 32-year gentleman who had a history of trauma 10 years back, and he had a history of some foreign body removed. This was the anterior segment finding, where we can see there was a site of entry, and there is a site of entry in the anterior capsule also, and there is a cataractus lens. The pressure is normal. This was the fundus which was hazily seen, where we can see a yellowish colored scar in the inferotemporal area of the macula. Fovea, the reflex was very dull. It looked like there was a macular hole. OCT was not passing over it, but this was the OCT passing over the lesion, where we can see a hyperreflective lesion which is in the subretinal or in the choroidal area, and there was intraretinal and subretinal fluid. B scan showed high reflective echo, which was persisting in the lower gains also. CT scan confirmed to be a foreign body in the inferotemporal area of the eye. As we can see, the ERG is also showing a negative B wave, so that is suspicious of early changes of cirrhosis. So the plan of management was to do a cataract surgery and start or think of removing the intraocular foreign body also. So phaco was done, and after doing the phaco, we could see that there was a lesion in the inferotemporal, and the PVD was induced utilizing a tricot. And when we were utilizing the tricot, as you can see, the PVD was not very easy in this case. The chandelier was put because we were thinking that probably we need to use a bimanual approach. So in this case, we did a small retinectomy at that point. And once the phaco was done, the lens was not placed, but a small PC opening was done so that we have a scaffold where we can keep the intraocular foreign body once taking out. So PFCL was placed to, if at all the foreign body falls from the hand. So the problem in this case was, as you can see, that foreign body is very densely adherent, and it is probably incorporated into the choroid. So when we are trying to pull it, the whole choroid and the whole lesion itself is looking to get elevated, as we can see. So in this case, we had to utilize the MVR or a 24 gauge needle to incise the part of the capsule and then take the foreign body out. And then is when the foreign body came out, and then using a handshake technique, we took it into the anterior chamber and then took it out from the corneal or the limbal wound. So right now, that's what we are seeing, that once it is out, I'm keeping it into the in between the scaffold where the anterior capsule and the posterior capsule is there, and then handshake technique utilizing to take it out. and then aligning the foreign body in the long axis and then taking out from the phaco tunnel itself. So once this was out, and then we had placed the lens, and then the rest of the area, because this was kind of a very chalky, small fragments, what we are seeing is probably the rust around the foreign body. So that was also removed, and then the inverse peel was done, and the case was closed with gas. And this was a post-op finding, as what we can see after surgery. This is 1 month where we can see a scar in the inferotemporal area and the macular hole, which is closed. Visual improvement was not very significant. So thank you for my presentation, and probably we take over the next presentation also.
Yes,
Yes,
yes. Thank you,
thanks.
Dr. Devyansh, for doing it this good and very nicely managed this case.